Welcome, everyone. I'm Linda Tintawi, the CEO at the Lustgarten Foundation, and I'd like to welcome you today to our celebration of Doctors' Day. And our webinar today is the importance of comprehensive care for pancreatic patients. And of course, on Doctors' Day, we want to celebrate the importance of the physicians in the lives of pancreatic cancer patients. Moderating today's discussion is Dr. Andy Rakeman, the Lustgarten's Vice President of Research, and we have three practicing physicians from Northwell Health, New York State's largest healthcare provider. Northwell has been the exclusive hospital sponsor of our New York area walks for the past 2 years, and we're thrilled to have their support again this year for the 2021 walk season. Now, we know this is a very important topic for pancreatic cancer patients and their loved ones who can be so overwhelmed when learning of their pancreatic cancer diagnosis. So I'm pleased to turn the conversation over to Dr. Rakeman, who will be moderating our conversation today. Hey, Andy.
Hey, thanks so much, Linda. So as Linda mentioned, I'm Andy Rakeman. I'm the Vice President of Research here at Lustgarten, but I think more importantly for today, I have the honor of being the host for my three esteemed clinical colleagues here to talk about comprehensive care on Doctors' Day. And I think comprehensive care is a great topic to start with and a great topic to have this group here to talk about, because I think that's really where the patient, the care team, and research all come together to really drive forward to do as best as we can and as best as we need to for our patients and our loved ones that are battling pancreatic cancer. So the way we're going to run this today, it's going to be mostly a conversation between me and my three colleagues here, who we'll introduce in just a moment. But if people do have questions, feel free to type them into the chat and we'll be monitoring those and we'll try to work them into the conversation or bring them up as we move forward. So we're joined here today to discuss comprehensive care with our multidisciplinary comprehensive team here. We have Dr. Herman, who is in radiation medicine at Northwell Health, Dr. Saif, who's in medical oncology, and Dr. Weiss, who's a surgical oncologist. So maybe before we get into the conversation, I'd like to give the three of you, actually, we'll start with you, Dr. Saif. Can you?
Yeah. Hi, good afternoon. Thank you very much for giving us a chance on the National Doctors' Day to be a part of this comprehensive discussion about pancreatic cancer. I'm Wasif M. I'm the Deputy Physician-in-Chief and Director for Medical Oncology at the Northwell Cancer.
Thank you very much, Dr. Saif. Dr. Herman, how about you?
Hi, Joe Herman, radiation oncologist specializing in pancreas cancer and also the Director of Clinical Research for the Northwell Cancer Institute.
And last and certainly not least, Dr. Weiss.
Yeah, so good afternoon. My name is Matt Weiss. I'm the Deputy Physician-in-Chief and the Director of Surgical Oncology for the Northwell Health Cancer Institute. It's great to be here. Thanks for inviting me. I have a special interest, obviously, in pancreatic cancer. I always tell people I love surgery and I hate pancreatic cancer. That's why I became a pancreatic cancer surgeon.
Excellent. So why don't we kick off the conversation really from the beginning here, and maybe this will be an open question for the three of you, whoever wants to start off, of, help us all really understand, what does comprehensive care mean? I mean, it can sound a little buzzwordy, but what are we really saying when we say comprehensive care, and why particularly for pancreatic cancer is it such an important to have this kind of a comprehensive approach?
Well, I'm happy to start off, Andrew. I think if you think about pancreatic cancer, the way it used to be treated was that it was treated almost in silos. Patients were diagnosed and they would maybe see a surgeon, or maybe they'd see a medical oncologist first, and then they would get some referrals and they'd see multiple providers. And what we've learned over the last, I would say 10 to 15 years, is that the way we can really improve outcomes for patients with pancreatic cancer is if we have a comprehensive team that takes care of these patients, and that team works seamlessly together in order to ensure that patients get the right treatment at the right time for the right patient. And comprehensive care really means treating the entire patient. I mean, I think it can't be emphasized enough that that when a patient is diagnosed with pancreatic cancer, that it really is a team sport. And there are multiple providers and disciplines that are involved in caring for patients with pancreatic cancer. And we try to develop a relationship with the patient that even expands past their medical treatment, their psychology treatment, their nutritional assessment, their genetics assessment. There's so many things that we have learned that go into treating patients with pancreatic cancer that can improve outcomes, that I think we now recognize that it's never been more important that patients with pancreatic cancer are treated by a team of experts in the field.
And I really appreciate that view of it's centered around the patient and put the patient first. And I don't know, Dr. Herman and Dr. Saif, do you have any from your practice or from what you've been setting up at Northwell? What does that really look like in terms of how the patients are going to interact into this kind of a comprehensive approach to their
Andy, I think Matt laid down the foundation very well. We all know that pancreas is a major organ with two major functions. We know this is the organ that produces a huge amount of enzymes to help you digest food. And also this is an organ that produces insulin and glucagon to control your glucose. So I think what I'm trying to make the point that not only that it becomes very important to understand that there are two kinds of pancreatic cancer, but also to understand the sequelae of all the complications that may happen in a patient following the diagnosis of pancreatic cancer. That is the reason we need to be thinking about as a comprehensive approach, not only in terms of finding out the right treatment for that particular patient, but also to manage the symptoms of the patient, because few symptoms are part of the cancer diagnosis and few symptoms are part of the pancreatic insufficiency, such as malabsorption, such as irritable glucose control. Many years ago, when I was interviewed, when I was working at Yale, I said one thing, that I don't treat cancer. And people say, what? And I say, that's true. I treat cancer patients. I think the key element is that when we treat pancreatic cancer patients, not only that we need to focus on the systemic therapy along with the radiation oncology and also the important part of surgery, that is the only potential cure, but really to incorporate the supportive care from day one is the way to lead to the best outcome for these patients. And I think that is the reason that it takes a really village to take care of a patient with pancreatic cancer with a comprehensive look that not only try to make things more based on the precision oncology, but also based on the tailored therapy based on that particular patient and the comorbid conditions and the social status where these people are with some of family support and other symptoms.
Yeah, I think maybe to add a little bit to what Dr. Saif and Dr. Weiss mentioned is there's a real synergy that occurs once the team comes together, and I think having now been at 3 different academic centers, I think the key is the team approach, as Dr. Weiss pointed out, in that I can honestly say now, after almost 15 years in the field, I can explain what a Whipple is. I can discuss the side effects of FOLFIRINOX, and both Matt and Wasif can also discuss, how is chemoradiation different from stereotactic radiation. And I think that synergy of coming together, of the team working together, is really important. And as a patient and a family, those are the types of things that you want to know as you're looking at, where you're going to get your care. I think the other thing that comes up a lot is what's the difference between a tumor board and a true multidisciplinary clinic, and how are they different? And I can say, there's a lot of different flavors per se of what multidisciplinary care looks like, but probably the most important caveat or the most important kind of what aspect that you would want to look for as a patient or a family is the team meeting, together. Are they discussing your case at the same time to make sure that those fine details that are unique to that patient are being openly discussed, that there's a consensus opinion that's occurring in real time, as opposed to one that's being communicated through email or other means where it's not, the whole picture isn't coming together. And I think what's really, even though COVID has been a challenge, I think it's opened up opportunity spaces in a sense that, I just recently joined Northwell about 7 months or now, but before I even came, Dr. Weiss and Dr. Saif have already created a virtual, MDC that allows patients from all over the system to be able to be discussed in a comprehensive manner. And that's really, now that we have teams, we might not be in person, but we are discussing the cases together. So I think many centers are evolving to be able to do that. So that, I think that's one of the big caveats and differences.
No, and that's a great point. And then maybe this is to push a little harder on that, maybe this is a good question for you, Dr. Weiss. So here we have a team with surgeon, a radiologist, a medical oncologist, who else would patients expect to see on their team if they came to a place like Northwell, or who else is involved in that multidisciplinary team that you're meeting with virtually these days?
Yeah, so I mean, I think, the team that we've developed, and I think a lot of, multidisciplinary groups have put together is not only cross-disciplinary in terms of the medical specialties of surgical oncology, medical oncology, and radiation oncology, but it's really designed to treat the entire patient. For instance, we include a psychologist that does, that screens patients for depression. Not surprisingly, if you get told you have pancreatic cancer, a lot of patients are situationally and appropriately depressed with that diagnosis. And it allows us to intervene and to help those patients deal with their depression. We include nutritionists. As Dr. Saif had mentioned, many patients that develop pancreatic cancer have pancreatic exocrine insufficiency. And actually, by the time they arrive to our clinic, are nutritionally deficient. We can have a nutritionist meet with patients and come up with a plan in order to optimize their treatment, both medically as well as nutritionally. We include pain specialists. Some patients that develop pancreatic cancer develop pain during the course of their disease, and sometimes that pain can be quite debilitating. And we like to involve our pain specialists in order to come up with a regimen or interventions that can improve patients' pain, which actually has been demonstrated to improve patients' survival if we can improve their pain. So there are a lot of people involved in the team, and all of them obviously experienced in taking care of pancreatic cancer patients. And I think, as Dr. Herman had mentioned, that group working synergistically together is how you get the optimal outcomes.
And it's great to hear about Northwell taking such a proactive approach to create the infrastructure that enables these teams to come together sort of from the outset. But if you, and I'm sure you all talk with patients from all around the country who are trying to seek out some expertise elsewhere, if somebody's in an environment where they don't have access to a hospital that's already built this kind of infrastructure, what are the kinds of tools that patients and their families can show up empowered with to try to help to get that? Or what are the questions they should be asking their care team locally to make sure that they're getting the same kind of 360 view on the patient?
Andy, that's a very important question. And I think the patient may ask simple questions about a doctor's experience. I think they should probably ask their physician, how many people with pancreatic cancer do you care for each year? What have been the results of these patients? Did they have similar diagnoses? They should also ask them, do they work with a team of expert physicians to manage the patient with pancreatic cancer? And who are those people in the team and their specialties? I think that's an important part. And then also the patient should ask some questions to themselves. And they should really think and talk to themselves and say, does the doctor seem to be interested? Does the doctor seem to be interested in answering my questions? What was the communication level of the physician with the patient? That's very, very important. I think in addition to that one, did I get enough time with the doctor to answer all of my questions? Sometimes the patient also need to feel comfortable. It's like a gut feeling, in terms of recommendations, evidence-based medicine. Keep in mind that pancreatic cancer is a cancer where treatments are very limited, and we are very much interested in genetic testing of the tumor so we can really define the right therapy for those patients. The patient should also be thinking that, will I be able to reach out to him or her if any questions came up? Do they have a system that and secondly, also sometimes the patient should think about seeking a second opinion. So I think all are the tools that the patient need to think about themselves and about the physician to really make the right decision for their therapy. But I think Dr. Matt Weiss can speak more for it. There's no question about that studies have shown that in centers of excellence where there's a high volume and expertise, those patients seem to derive the most benefit and also seems to have a longer survival.
Yeah, I couldn't agree more, Dr. Saif. I mean, I think you paraphrased it perfectly that these are relationships with patients. And I think patients need to feel comfortable with their team and with their team's experience level and with their team's even just simple conversations. I like to think about the initial questions that patients ask into a couple of different categories. There are the simple questions that are related to the type of tumor they have, the stage of the tumor, kind of medically based questions. And then there are other questions that become equally important in terms of what the prognosis is and getting to know your provider so that you can truly embark on what I call a journey together These patients are our patients for life, and the comfort level of the patient with their provider is essential. I think, classically, a lot of centers of excellence, I like to say this with Dr. Saif and Dr. Herman on the line, were related to surgical expertise, because classically most treatment was related to surgery, and we defined excellence by volume. But what we've learned over time is that clearly surgical excellence is important in terms of outcome. But actually, what's equally as important, we now know, is the medical oncology systemic therapies and the radiation oncology therapies together. That we should define excellence based across disciplines, as opposed to, I'd love to think it's all about the surgeons because I'm a surgeon. But what we now recognize is that the way we move the needle forward and the way we improve outcomes is with the other disciplines like medical oncology and radiation oncology being equally as important in terms of their expertise level. So I think assessing the expertise level of your entire team is very important.
Yeah. So if I'm going to paraphrase a little bit of what you said, it's making sure that the expertise is all there. But I think to your earlier point and what Dr. Saif said, it's also the patient feeling as if they're part of that team and they're engaged across, and they're as well integrated in terms of the communication and understanding as you all are with each other, being part of that too.
And
Dr. Herman?
Andrew, maybe to add one thing too, I think it's important is, really is does that organization also partner with organizations like Lustgarten and PanCan and others? I think there should be a commitment of the centers to also be, engaged and involved in the education of patients and caregivers, to be engaged in different grant mechanisms that are focused on pancreatic cancer, and show that investment ideally. And I think those are things that transcend, the entire encompass of care. And you mentioned also, I think it's our responsibility that if someone comes to see us for a second opinion, whether it be in person or now with virtual opportunities, we each of us at different centers across the regions that have that expertise can do virtual consults. And I think we have a willingness, obviously, at the end of the day, to be patient-centric. And there are times where we might not have the trial available, or we might not have, if they live really far away, where we do need to take that initiative and partner with other colleagues across the country to help make sure that they get the care that they need. And I think that willingness to be objective and really supportive regardless, I think, is another thing that patients should look for.
Yeah, thanks, Dr. Herman. And I think that's where I kind of started. I really see this is the topic where all three of those points come together, right? Between the patients and the patient advocacy organizations, the clinical care team, obviously central, and the research. And maybe that's a good transition too. I can ask you, Dr. Saif, because I know you're very active in a number of clinical trials, testing new therapies and really expanding on what's possible and what we want to learn about pancreatic cancer in terms of how the diseases manifest, as well as how to better treat it. So maybe if you could talk a little bit about kind of what's happening in the world of clinical trials and how your engagement in the clinical research side of things is influencing your approach to clinical care as well.
I think, Andy, that's an extremely important thing to keep in mind, that we all know that pancreatic cancer is a disease that we encourage, and not only we encourage, the National Cancer Institute also encouraged that every stage of pancreatic cancer should be a candidate for clinical research. And we already learned from our experience that pancreatic cancer patients who participate in clinical research have better outcomes. Every treatment available today was also approved through a clinical trial. So I think that's the reason I believe that clinical trials are the research tool that not only investigate new treatments, but also the combination of the previous therapies or the incorporation of multimodality therapies, such as you heard the name FOLFIRINOX, which is one of the most active regimens. Using that regimen in a patient who's going to be resectable pancreatic cancer stage, how we can really improve the margins and bring out a negative margin, which means that we really take the tumor out completely without leaving anything microscopic. All those things are extremely important. But we also understand that this is an era of precision oncology. What it means that we really look for knowing the biology of the tumor, look for different specific mutations, genetic mutations in the tumor, and then try to target the tumor according to those genes. We know that in the history of pancreatic cancer, the first drug, olaparib, was approved based on the clinical trial called the POLAR study, where the patients who nurture or carry the BRCA1 and BRCA2 mutation, which is the breast cancer gene mutation, were found to have a benefit by receiving this new drug, which is a PARP inhibitor. We are really moving forward into a new direction, and as you know, that we all work together as a team. So definitely, we need help from each other in terms of pursuing the best pathway. The cutting edge treatment can be brought to our research and then finally, hopefully improve the treatment for our patients. We're working very closely with Port Spring Harbor Laboratories and participating in an international clinical trial, which is called PAS-01 study. PAS-01 study is unique in its own way, not only that it is an international study that encompasses people from different elite institutions to work together, but this is a clinical trial that for the first time in the history of pancreatic cancer, we are going to be collecting tissue specimen from the patient. That specimen will be now developed into something called organoid. Organoid is basically a small miniature size tumor, which will be developed in a petri dish from the tumor of the patient. And then we will learn about the sensitivity of chemotherapy and other drugs to that tumor specimen called organoid. This is an exciting study that will allow us to learn about in advance that what is the right drug to be given to that particular patient. We're also learning, as I mentioned earlier, how to incorporate chemotherapy in early stage pancreatic cancer. Dr. Matt Weiss, myself, and other colleagues are working on what we call neoadjuvant, where we give chemotherapy pre-operative or pre-surgery to try to see that by giving chemotherapy prior to surgery will lead to more complete resection with nothing left behind microscopically. We also know that pancreatic cancer is a disease of old age. Yes, we see patients in early age also, unfortunately, but in general, this is a disease of the 7th decade, people in their 70s. We also know that the new cutting edge chemotherapies such as FOLFIRINOX or the combination of gemcitabine with Abraxane or nab-paclitaxel are very, very exciting drugs, but also carry a load of side effects. And that is the reason we're also now looking at a particular group of patients who are above age of 70 or patients who are in the not most functional status to try to give them chemotherapy in a different schedule. So see whether that schedule of chemotherapy, for example, gemcitabine plus nab-paclitaxel historically was approved based on the clinical trial where chemotherapy is given on a weekly schedule for 3 weeks on, 1 week off. We ourselves publish the data, and also our colleagues from other places publish the data in patients who cannot tolerate the chemotherapy 3 weeks in a row. If you give them chemotherapy once every 2 weeks, can give you more or less similar outcome and a better quality of life. Definitely that data is not validated in a prospective study, but now we are contributing to a study called GIANT study, where we're trying to really test these modified regimens in patients who are above 70 and who are in a functional status 2, not 0 and 1, which was seen in the initial studies. So I think if you look over here, again, the term comprehensive fits so well by the title given by you and the Lustgarten Foundation, that research is a comprehensive look at the overall outcome for pancreatic cancer. We're not only looking to really make sure that we have better therapies, we're looking for better tolerance, we're looking for newer agents, we're looking for better combinations, we're looking for better order of giving these therapies, along with trying to learn more about the biology of the tumor and try to learn at the level of the basic science, which can guide us further how to treat this cancer.
Yeah. Thank you, Dr. Saif. I think you brought up a lot of very important points. I think people are very used to thinking of clinical trials as just the tool to get new drugs approved. But as you point out, it also teaches us, help us to identify new drugs, but who best to use them in and how to identify those patients. Identify new tools, like you said, screening for genomics, which can identify drugs that will work specifically against a certain patient or a certain tumor. And now bringing in new technologies such as organoids to make that work even better. And I think one other point that you talked about that maybe we'll push a little bit deeper with Dr. Weiss is also this recognition that medical oncology, radiation oncology, and surgery are not 3 separate disciplines, but they're all there to support each other towards a one goal. And I know Dr. Weiss, he started off by saying is, that traditionally the surgeons and the oncologists were up in 2 different worlds, and patients made a choice and they went to one or the other. But that's really changing. And maybe you can talk a little bit about the role of a surgeon in treating pancreas cancer and how you work closely with your radiation and medical oncology colleagues to really make sure you tailor the treatment to the patient?
Well, I think my favorite line of the webinar thus far was when Dr. Saif admitted that surgery was the only potential cure for pancreatic cancer. But the reality is that we are actually curing more patients with pancreatic cancer with surgery today. But the reason we're doing that is because systemic chemotherapy has gotten so much better, and the technology in radiation oncology has improved so much. One of the things that we learned from some of our trials in what I'll call locally advanced tumors, meaning no evidence of metastatic disease, but tumors that are involving major blood vessels. What we learned through trials was that actually imaging can sometimes underpredict how patients are responding to chemotherapy and radiation therapy. So through trials, what we recognized was that nowadays, if you have contained disease, that a CT scan, an MRI, a PET scan actually can misinform us as to how much you've responded to therapy. And now most patients will undergo at least an attempt at a surgical resection. And what we learned, and we published these data, is that a lot of times these tumors are resectable. And sometimes patients have even had a complete pathologic response to chemotherapy and radiation therapy. Or at least we have a higher margin negative, meaning not leaving tumor behind resection rate, and a higher lymph node negative resection rate, meaning chemotherapy and radiation therapy has increased the number of patients that are actually able to undergo surgery. And it's also improved the pathologic outcome of the tumors that we do remove in patients. So going back to our earlier discussion, patients that are told that they're not candidates for surgical resection, that have just contained local tumors, they're patients that should get a second opinion or a third opinion. Because we all have countless examples of patients that have been told they are unresectable surgically, that, quote, didn't respond to chemotherapy or radiation. And then we remove their tumor, and many of those patients have been cured of their disease. So, again, chemotherapy, radiation therapy has made my job a little bit easier. It's made more patients candidates for surgical resection. And I think it has enabled us to be a little more aggressive when it comes to surgery. In the old days, it wasn't that surgeons technically weren't as good, so they didn't do big, complex operations, is that they knew that biologically, even if they did more complex operations, that unfortunately the patients frequently would recur with tumor. Now that chemotherapy's gotten better, radiation therapy's gotten better, and we can control systemic disease, the operations for pancreatic cancer are actually currently becoming more complex and more aggressive, and I think rightfully so.
Yeah, and I think that it's important. I think it underscores what we're talking about here of this coordinated and comprehensive care, of understanding that the best options is when we can open up every tool in the toolbox to be able to be used and find the best way to use them together. So maybe then we'll turn to you, Dr. Herman, and you can give us from the radiation perspective, help give us, describe a little bit better for everyone, because I think people can get confused here about what the role of a radiation oncologist is, how they may be different from a radiologist, and how sort of you fit into the picture here and what you'll be looking for in patients and how to contribute to the overall success.
Sure, thank you. I think first to just give a little bit of a basics in terms of how does radiation work. So radiation, it does come in different forms, but I'm going to focus on what's called external beam radiation therapy, which by definition, external means that we have beams of radiation that come from a machine called a linear accelerator generally, that come in and it goes through the skin into the body and it converges in one point in space, which is, in this case, where the pancreas tumor would be, for example. Historically, we used to treat with really big fields of radiation, almost, like big lamps per se, that would come in from the front and from the back. And although we would hit the tumor, we hit a lot of normal tissues and patients would become very ill. So 15 years ago, when I first started treating with radiation, we would treat patients for 30 days. They would become very sick. They had a lot of side effects. About 30% of them would need to get admitted to the hospital. And not to mention, it took 5 to 6 weeks of their life because they'd come in every single day for that treatment. And frankly, that took away from time that they could be with their family or time that they could be doing other things to enhance their own quality of life. Because of improvement in technology, we can now focus radiation really down to the millimeter accuracy. So if you imagine, again, the pancreas is in a really tough spot. It's in the middle of our body. It's around bowel, it's around liver, it's around other normal structures in the stomach, et cetera. So we have to be very accurate, not only that the radiation itself has to be in the right place, but what we're doing now is we're controlling breathing. We're having patients either hold their breath or we're tracking it as they breathe, kind of like almost target practice per se. And then we also can put little markers in there to track, make sure exactly that we're hitting the tumor in the right place. And then finally, what's really emerging is better imaging. So MR guided radiation, better CT guidance. We can again be very accurate to make sure that exactly the area we're trying to hit with radiation is the area that we're treating. So what does this mean in general? Is it means that we can now deliver radiation in 3 or 5 days as opposed to 28 to 30 days. It also allows us to do it with much less toxicity. So now our patients can come in, they come in for about 30 minutes, they go home, and generally they might have a little bit of tiredness, a little bit of nausea, but that can be controlled medically. Plus that decreases the delay of receiving systemic therapy. So as Dr. Saif mentioned, FOLFIRINOX right now or Gem/Abraxane are the two kind of the big heavy hitters per se. So if we can minimize the time that patients are getting radiation, it allows patients to stay on that systemic therapy faster or longer. And it also, if we want to get to surgery after we've maximized chemo, give a short course of radiation, it also doesn't delay that interval between radiation and surgery. So we kind of speed up the clock a bit. I think the last thing just to mention though is that where we're evolving and where the future is better understanding which patient should get radiation. Similar to, as Dr. Saif mentioned, with looking at PARP inhibitors and others, I think we need to think of radiation in a very similar way that we do with other targeted therapies, in a sense that we need to identify which patients are going to be the best candidates, both by molecular profiling and sequencing and other things, as well as using imaging correlatives to be able to understand, when and which patient should get the treatment. And then one more thing I'll just mention is it's an exciting time that because of the short course of radiation, it allows us to combine it with other therapies. So for example, immunotherapy or other targeted therapies that are evolving, so that we're studying how can we use radiation to enhance the immune response, for example, to make tumors that historically are not immune sensitive, that we can now make them immune sensitive perhaps. And then also, we used to be limited to just treating the pancreas, but we're seeing now that patients that, or let's say they even have metastatic disease or they have disease outside of the pancreas, there's unique circumstances where radiation can be delivered to the liver, to the lung, or to other areas to try to keep people on systemic therapy longer. And or if they have pain or other symptoms, we're integrating radiation much more rapidly in terms of supportive or palliative care for patients so that they can, again, be healthier, feel better, and again, ideally stay on a systemic therapy that's working in other areas for a longer period of time.
I mean, so if I'm gonna, and maybe I'm oversimplifying here, but it sounds like the common theme across the three disciplines here is the more selective you can get for the patient you're delivering, the safer the therapies you can deliver, whether it's a surgical or radiation or drug intervention, the more patients you can do, the faster you can change course. And that's really where that constant communication becomes important. And maybe before we come off of this topic altogether, just to follow up on where you touched at the end there, Dr. Herman, of, how much of this changes when there's metastatic disease, which is unfortunately all too common in pancreatic patients when they show up at diagnosis. And, how much does that really alter what's available and how we think about what treatments are in not only presence or absence of metastases, but where those metastases are going towards. I mean, are there sites where it becomes too difficult or will shift to one or the other discipline as the primary source for treatment?
Well, I think first of all, it comes back again to that relationship and the partnership. So I think, for example, the three of us, if we have a patient that we're sharing, we will communicate often. So I think initially a lot of places will do a multi-D evaluation in the beginning. And then, if it's metastatic disease, they'll never see a radiation oncologist or a surgeon again. And I think what's really great about our relationship is we're always thinking about how do we maximize and combine our therapies to help patients, across the board. One way is looking at trials. So we are looking at opening a trial for oligometastatic disease, which is this setting where you have certain, tumors in, let's say, up to 5 areas, for example, in the liver or the lung or other areas. There's someone that mentioned in the chat about the brain. It's very rare, but I think, again, thinking about where can you integrate a short course of radiation in areas that will help control the disease better and combining it with systemic therapy. I think an important point to make, though, is that we still rely on systemic therapy first. So chemotherapy, targeted therapies, ideally first to try to get control of the disease. And then if there's one or two areas that are growing, rather than switching to a whole nother regimen, the value of combining with surgery in unique cases or radiation or even ablation with our interventional radiology technologies. So thinking again, how do we partner together to control the disease with the least amount of side effects, with hopefully the best benefit, and ideally on trials, which is what we're trying to integrate prospectively.
Great. And so maybe now here we'll shift gears a little bit. I know we've talked a lot about, so far, how do the three of you team up to treat the tumor as it's progressing? But, a lot of what's most concerning for the patients and the families is often not just the tumor, but the side effects from the drugs and the other side effects that the tumor can cause. And that's often, as we started this, can be very limiting in terms of how much treatment, how intensive can be. And that's why the importance of involving nutritionists and psychologists are important in there. So, and maybe this is a good question for you, Dr. Saif. What kind of things should patients and caregivers and families be thinking about in terms of approaches to better control symptoms and side effects, or who should they be talking to be making sure that they're getting the best care in terms of the quality of life and the side effects from treatment?
Randy, as you know that I like to mention, and I'm quite sure you heard this thing before, medicine is a science, but when we practice, it becomes an art. I think the most important part is that, managing the symptoms and side effects of treatment, we need to remember three things: education, education, education. It is extremely important to educate the patient and the caretakers. I think that's so important because the patient will be the one who will notice the side effect first. Number two thing is reassurance, reassurance, and reassurance. And the reason I say it three times because keep in mind that side effects of the chemotherapy are potential side effects. They may or may not happen. At the same time, with our vast experience of dealing with these drugs for so many years, we can manage those side effects by either modifying the dose or by changing the regimen or by using some simple, medicines. But I think more importantly, this is again a team approach. We work very closely with our palliative care people. We're very blessed to have Dr. Diana Martin-Welch, who's my colleague who works hand in hand with me, with our nutritionist, who not only talk to the patient, but also to keep developing new handouts for the patients to really look into many different things which are important in terms of the quality of life or in terms of any interactions with different chemotherapies. I think one example is nausea. We always think of nausea, okay, so how to manage nausea? Believe it or not, there are simple steps that a nutritionist from your team can help the patient to improve the nausea and vomiting by just changing their eating habits, by just telling them to eat small 4 or 5 meals a day rather than 3 big meals, taking your time really when you're eating and chew it well and drink an hour before the meals rather than when you eat, trying to also take some flat ginger or tea that may help, or avoiding some strong smelling foods. And then, of course, we can talk about the anti-nausea drugs to be given to these patients. But at the same time, we have multiple anti-nausea drugs. Few of them we give them in advance before giving the chemotherapy, but also the drugs which are given to these patients as a prescription to be used as needed are also very variable based on the patient, based on the other medicine they're taking, based on the potential interactions. So again, as I say, it takes a whole village to take care of the patient with pancreatic cancer. And we take every pride and every effort and every part of diligence with our team to make sure that we try to make it as easy and as possible for our patients to feel the least of those effects. Now you brought up a very important question about quality of life. So the quality of life is really part of the quality of life by how to manage the symptoms of the cancer. And as you know, that the treatment, either it's chemotherapy or radiation therapy or surgery, some of the symptoms, either is pain or obstruction and many other things can be really alleviated through those things. Keep in mind that quality of life also means that if somebody has biliary obstruction, they can have a stent placed in the bile duct to open up. In addition to that one, the role of palliative care people in terms of managing the symptoms of the patient. And again, as I mentioned earlier, that also trying to understand what the pancreas gland means in the body, what are the functions and dysfunctions when the patient develops pancreatic cancer that may need even a role of an endocrinologist to help me with a brittle glucose level and diabetes in a patient. People can develop clotting or thrombosis with pancreatic cancer. So I think the bottom line is that it is very clear from the first day of my experiences in life, which has been over 2 decades, I learned very clearly, you don't wait for the last moment. You really get the supportive oncology, the palliative people involved from the day you start the chemotherapy. And at the same time, there's no bigger tool than educating the patient and the caretakers.
Yeah, I think that last bit, Dr. Saif, is a very important point. If you sort of waited until it's become a problem, it's already too late, right? And really engaging with having the tools at the ready before you need them means that they can be deployed that much faster and will be that much more effective is really a important point there. I'm gonna take a pause here. We've definitely more to talk about. We have about 15 more minutes left to talk, but just to remind folks, if they do have questions or points that they want to hear more about, to feel free to type them in the chat. And I think we've already talked about quite a bit, right, in terms of one, what does comprehensive care mean? How this comprehensive care really allows us to be quite adaptive and bring in the latest research moving forward, and to bring in this dynamic team. We've talked about some examples of recent innovations that have happened, that have really begun to change not only how we think about pancreas cancer, how we treat pancreas cancer, and outcomes starting to shift a little bit for patients dealing with pancreas cancer, but it's also clear that we're not there yet, and that we still have more to do and more to go. And I think any individual or any family that's dealing with a diagnosis of pancreatic cancer feels that all too acutely right now. So maybe now's a time to kind of open up a little bit and think of the future, and think both in a realistic way, but also in a blue sky way. I'm going to ask the three of you kind of what are you most looking forward to of the things that you see on the horizon that are going to give you some better options and some better tools, and help to really change the lives of your patients moving forward. And so maybe we'll go the opposite order in which we started. And so I'll start with you, Dr. Weiss. Kind of where do you see the future of things going?
Yeah, so I mean, anyone that knows me knows I'm the eternal optimist. I think the future is bright. I think there's a couple things that truly excite me right now. In terms of, number one, in terms of kind of the comprehensive care and multidisciplinary care, I think we're in the process, as well as 5 other sites, of actually studying why comprehensive care improves outcomes in order to try to improve the program. It's through the Canopy Cancer Collective Network. It's through some seed funding from the 1440 Foundation. And what this is 6 sites that actually evaluate how our multidisciplinary approach affects patient care, and we learn from each other. It's actually a learning network. Very, very exciting. I think we can improve upon the way we approach cancer in a multidisciplinary care based upon this. It's interesting. This group of 6 centers of excellence is dispersed across the entire United States, and we just opened it up to 6 more centers, and we already have 17 applications showing that these types of collaboratives are coming to a place near you if you're a patient, which I think is exciting. The other thing that I'm excited about is partially what we're doing with Cold Spring Harbor Lab and with Dave Tuvison in the group, in that we need 2 things. Right now, we have 2 main regimens of chemotherapy we use for pancreatic cancer. And to be honest with you, the way we decide which therapy a patient is going to get is basically a flip of a coin. We don't have a reliable way to predict which chemotherapy patients are going to respond to. And then I'll go a step further. We don't have a reliable way that we can measure whether a patient's actually responding to therapy. So we do CT scans and we do labs, but as I said earlier, it can be difficult to actually gauge response. I think I foresee in the not so distant future, in the near future, a situation where a patient will get a biopsy. The biopsy will be predictive, will be grown in a petri dish called an organoid. We'll predict what chemotherapy that patient is most likely going to respond to. And then when they start on therapy, we're going to have real-time mechanisms by which we can actually measure and gauge their response, so that we know that the chemotherapy that we're giving is working. And then we can better inform ourselves based upon that who we should operate on and when we should operate on them and when we should integrate radiation. I don't think this is in the distant future. I think this is real time. We have a study that's opening very soon looking at measuring response to chemotherapy with a simple blood test for patients that are going to go to surgery. And so I'm excited. I think the future is bright. I tell patients all the time that years ago, we gave chemotherapy that was very toxic and wasn't very effective, but those times have changed. Chemotherapy has improved, it's better tolerated, it's more effective, and now we need more sophisticated mechanisms to actually tailor how we're going to treat patients. And that's what I'm the most excited about.
Yeah, no, couldn't have said it better. I don't think anyone else can. So now maybe we shouldn't have gone with you first, Dr. Weiss, because it's going to leave not a lot of room for anyone else to add. But Dr. Herman, is there anything else you want to build on?
Well, I think he summed it well. I think one other thing that's really exciting is, you know, how do I put it? The focus on this disease. I think, you know, frankly, having done this for 15 years, my heart goes out to the families. This comes as a shock to anyone that gets diagnosed with pancreas cancer at that moment. And frankly, if it wasn't for the donations and the contributions of many individuals over the years, including obviously those that involved with Lustgarten and other organizations, but you know, just mention that, you know, we saw in the chat box. So Gail Coleman is one of the key funders for the organoid project at Cold Spring Harbor. And so, you know, even though we make every effort to put out grants and we do everything we can to increase resource allocation to this disease, which, as many of us know, is very close to being the second leading cause of death in this country, that we need to do more work, and we all need to be, this needs to be, I mean, we say this a bit, that COVID has been so hard and so challenging, but, you know, the effort that went into that's been able to create, you know, trials that open and close rapidly. We need to learn from those initiatives and that urgency that we have for COVID. Just think if we can use that same urgency in this disease and other cancers to really develop the right trials that really get to each patient. I think the other thing is exciting is vaccines. The vaccines that when I was working at Johns Hopkins with Liz Jaffe and others, you know, we started doing some really exciting vaccine work, some of which I think has had really great effects on certain patients. You know, but I think the future is exciting as we're now developing more personalized vaccines based on individual cancers. And I think we know that that's important based on some of the work that Chris Icabuzio and others did in autopsy patients, where we know that, you know, the disease that a patient started with may not, and it likely is not the same cancer that goes to the liver or goes to other parts of the body. So I think the more that we learn about the natural history of this disease, the better that we are equipped to work together. Again, it comes back to the multidisciplinary infrastructure. And really, just to add, we didn't really say this directly, but the relationship with Cold Spring Harbor, or the relationship that other centers have with their pathologists and radiologists and also the basic scientists, the more that we can bridge those gaps, the more rapidly we can get novel therapies from the lab to the patient, and also detect patients more effectively and earlier in this disease. So anyway, it's an exciting time. I'm like Dr. Weiss. I mean, although this is tough and it's still a tough cancer every day, I'm excited to come to work and to be able to fight this disease. And I'm inspired by the survivors, the patient advocates that put their time and energy into it, and others, and appreciate the opportunity.
Dr. Saif?
So I think, Andy, when I think about pancreatic cancer, it takes me 20 years ago when I was a fellow at the National Cancer Institute. And I do remember that at that time, we developed gemcitabine and were trying to look into capecitabine, irinotecan, 5-FU, oxaliplatin. And, you know, people, when they go and tell this and meet their friend, they say, you know, my grandmother told me a story. In my case, I am very proud to say that I was a part of that story. I contributed to development of all these pathways, all these new drugs, all these regimens. And I think that gives me the force, the hope, the confidence that we are going to have a better future for our patient with pancreatic cancer. Believe it or not, when I chose to devote my life to pancreatic cancer research, many friends, family members came to me and told me, are you crazy? This is a tough one. And I told them, somebody got to do it. So I think we are not only committed to learn more about pancreatic cancer, to learn about the pancreatic patients and the novel pathways that we want to attack. I think we're also devoted our life to help the pancreatic cancer, but train the newer generation of oncologists, surgical oncology, radiation oncology, and the rest of modalities who can do even a better job than us. So I think it is very important for me also to thank you and thank all the people who are listening to us, because you are also a part of hope and encouragement. Because Lusk Garden Foundation and many other foundations, they were developed to give a kind of hope to people like us and Matt and Joe, that who really want to really do something for these patients. And I think that everything that you're doing really gives that extra heartbeat to our hearts and give them more energy and more hope that we can change the total outcome of pancreatic cancer in future.
Yeah, no, thank you. And I think you all said it so well. And I think the one thing I'm being struck with that's certainly come across through this is the type of approach that you're taking at Northwell in terms of patient care, really trying to bring the team together. And it's the focus on the patient and focus on the outcome that you want to achieve, is the same kind of approach that we really need to take across the board in addressing pancreas cancer, whether that's from the research side, where we've heard about advances in immunology and advances in radiation and development of new drugs and new biomarkers and understanding the fundamental biology. And those are all different people with different expertise that we need to be able to bring together at the end of the day. And we know that, all of this, starts and ends with the supporters and the families who have been impacted, and they need to be, along as part of this, and us listening to them about what's important and giving us the support and the motivation and everything that's needed in order to drive this forward. And I think that's why, Lusk Garden and Northwell make such an excellent partnership in bringing together two sides of that. And driven, I think, by that common mission of focus on the patients. I'm gonna make one more comment, then I'm gonna give the three of you each one line for parting advice to give to patients, and then we'll turn it back to Linda to close us out. And mine is just to notice anybody online who is looking for additional resources, please go to luskgarden.org. We do have materials there, patient checklists, patient handbooks that can be really helpful in terms of guiding you in a journey, or guiding you with information or contact, or who to get in touch with moving forward. So really do encourage you to go there. And also to pay attention for folks that are looking to learn more about what's going on with research and moving forward. We're going to continue to have events like this, and we'll have another one focused on earlier detection of pancreatic cancer coming up in April, that I hope everyone will be able to join us for that as well. So again, I think just maybe one line, 1 minute each before we give it to Linda to close us out. We'll go the other order. So, what would be your one line parting advice to patients or families or anyone who's facing a tough diagnosis as they go forward? Dr. Saif?
So I will only say one thing: you're not alone. We are here for you, and we are committed.
Excellent. Dr. Herman?
I think be your own advocate and seek education, seek information, and don't give up.
Dr. Weiss?
I would say for me, I want people to know there is very realistic hope. There is hope. I see the needle moving. Every day that the three of us go to work, there's an emergency. And that emergency is that our patients have pancreatic cancer, right? I and everyone on this call recognizes that there is a time urgency to this. We should not be focused on incremental improvements. We need radical improvements. And that's what I think this team and others are focused on now. This is why it's important to get the clinicians together with the basic researchers to make sure that we get that research into the clinic to save the patients that have pancreatic cancer today.
So you're not alone. You have power. There is hope, and this is urgent. I mean, I think that's the mission statement for all of us. I don't know. Linda, do you want to close us out?
Sure. And thank you, Andy. And radical improvement. That is what the Lusk Garden Foundation is all about. And we are thrilled to partner with Northwell Health, Dr. Saif, Herman, Weiss. Your compassion, your care, your expertise and determination is just an inspiration. So thank you on behalf of Lustgarten. Thank you on behalf of our patients and our patients' families. And we look forward to continuing our partnership and to working together in the future. So thank you all, and we'll see all of you hopefully on April 21st. Please join us and please continue to follow us on social and on our website, and we'll see you soon. Thank you all.
Thank you very much.
Bye, everybody.